December 2018, paper 3. Most of the questions from this paper has been covered before. I'm repeating that questions: infective endocarditis prophylaxis, Kawasaki, HSP, adolescent immunization, hyperkalemia, and portal hypertension. So the rest of the question we are covering here. Let's start with clinical features of juvenile dermatomyositis. So as the name suggests, juvenile, dermato, and myositis. So it affects children between 5 to 14 years. And it is autoimmune inflammatory myopathy, or the inflammatory condition as the name suggests, dermato and myositis. So myositis means muscle weakness, so it does proximal muscle weakness, cutaneous manifestations, and it is also accompanied by systemic inflammation. So the clinical features are divided into 3 categories. Muscle involvement, the characteristic of muscle involvement is symmetrical, proximal, muscle weakness, that is difficulty in climbing upstairs, getting up from the sitting position, so difficulty in getting up from sitting. This is called as Gower's sign. This sign is positive in DMD also and juvenile dermatomyositis also. Difficulty in lifting arms. So these are the signs of symmetrical proximal muscle weakness. Other features of muscle involvement: neck flexor weakness, along with muscle tenderness and pain. Dysphagia due to pharyngeal muscle involvement. Dysphonia due to larynx involvement. After muscular involvement, cutaneous manifestations. These are dermatologic hallmark. These are the hallmark of the disease. There is characteristic heliotrope rash. That means there is violaceous discoloration of eyelids along with periorbital edema. Second characteristic dermatological finding is Gottron's papule. There is raised, scaly, erythematous, and violaceous papule over knuckles. Elbows and knees. There is also Gottron's sign positive. Gottron's sign, that means erythematous, violaceous, rash over extensor surfaces. That is elbows and knees. There is photosensitive rash. And they are present over face, neck. In the neck area, it forms V sign, shoulder and upper back. That is called shawl sign. The next is nail fold capillary changes. That is dilated, tortuous capillaries around the nail. These are the cutaneous manifestations: heliotrope rash, Gottron's papule, Cotran sign, photosensitive rash that shows V sign and shawl sign and nail fold capillary changes. And other than these, there are some systemic manifestations. Constitutional symptoms. Like fever, malaise, and weight loss. Gastrointestinal manifestations, abdominal pain, ulceration, and perforation can be there. Pulmonary manifestations, interstitial lung disease. There can be myocarditis or arrhythmia. Articular involvement, arthralgia or arthritis. So these are the clinical features of juvenile dermatomyositis. Juvenile means age 5 to 14 years, skin, muscular involvement, and the systemic manifestations. The next question. Pathogenesis of Eisenmengerization. In short, what is Eisenmengerization? There is a long-standing uncorrected congenital heart defect. That is left to right shunt. Presence of long-standing left to right shunt which is uncorrected. This leads to pulmonary vascular remodeling, this leads to pulmonary hypertension, and this leads to shunt reversal. That means that left to right shunt converted into right to left shunt, and this conversion is called as Eisenmengerization. Let's learn this stepwise process. first step is, initially there is a left to right shunt. Suppose there is right ventricle. There is a ventricular septal defect. In these conditions, generally, systemic pressure is more than pulmonary pressure. That is, left side pressure is more than right side. Example of these conditions are VSD, ASD, and PDA. So this is the pulmonary circulation, and this is the systemic circulation. So blood is flowing from left to right side. Because systemic circulation, systemic pressure is more than pulmonary pressure. So what are the effects of left to right shunt? All the blood from left side come into the right side, that means from pulmonary, that means to the pulmonary area. So it increase pulmonary blood flow, and mildly increase pulmonary arterial pressure. So it increase flow at the pulmonary area and increase the pressure at the pulmonary area. And gradually this leads to chronic pulmonary overcirculation. Because with time, as this condition is uncorrected, so there is persistent high flow as well as high pressure in pulmonary arteries. The right side, this is the left side. So because of continuous left to right circulation, there is overload at the pulmonary area, continuous increase in pressure and flow at this area. And this continuous pressure leads to endothelial injury. So there is damage to that endothelium. And this starts pulmonary vascular remodeling. So this endothelial damage triggers proliferation of smooth muscle, hypertrophy of the muscle, hypertrophy of smooth muscle, loss of capillary bed, and ultimately fibrosis and thickening. This leads to rise in pulmonary vascular resistance. That is PVR. Because of continuous pressure, these vessels are now thickened. There is fibrosis. With this progressive remodeling, the reversible increase in pulmonary vascular resistance become irreversible. Ultimately, there is reversal of pressure gradient. And this is called as Eisenmenger stage. So gradually pressure in pulmonary circulation exceed and become more than systemic circulation. Because of increase in pressure, the flow reverse and has become right to left. So blood start flowing from right side to left side, and right side there is a deoxygenated blood. So deoxygenated blood get mixed into oxygenated blood, and consequences of these reversal is, so previously there was no any cyanosis, now cyanosis settle up. So because of right to left shunt there is cyanosis. Clubbing started appearing because of chronic hypoxia. Polycythemia, because it is the compensatory response to hypoxia. Hyperviscosity, embolism, and ultimately right ventricular hypertrophy, which leads to heart failure. This is the pathogenesis of Eisenmengerization, chronic long-standing uncorrected congenital heart disease, which is initially left to right, gradually converted into right to left. This is called Eisenmengerization. To the next question. Diagnosis of cystic fibrosis. So diagnosis of cystic fibrosis start with initial clinical suspicion. So clinical suspicion arises when there is a child presented with who is suffering from recurrent pneumonia, having chronic cough, wheezing, if the child is failure to thrive, history of meconium ileus, and also there is family history of cystic fibrosis. The suspicion of cystic fibrosis should be arise in the mind. What are the confirmatory diagnostic tests? First is sweat chloride test. The sweat chloride test is gold standard test. This test measures chloride concentration in sweat. on measuring the chloride concentration in sweat. What are the interpretation? When the value of sweat chloride is more than 60 millimole per liter, that is the diagnostic of cystic fibrosis. When this value is between 30 to 59 millimole per liter, this is the intermediate result and it needs further testing. When this value is less than 30 millimole per liter, it is normal. The patient is normal. The second test is CFTR gene testing. This identifies mutation in CFTR gene. The most common is delta F508. The next test is nasal potential difference. It measures abnormal chloride ion transport across the epithelial cell. But it is rarely being done. When sweat test and genetic tests are inconclusive, then only it is being done. Third type of investigations are ancillary investigations. That means the supportive test, which indirectly indicate the possibility of cystic fibrosis. Sputum culture of the patient shows Pseudomonas aeruginosa, Staph aureus, and Burkholderia. Pancreatic function test. Now it is being detected in newborn screening. Newborn screening test. Now it is universal in many countries. It involves heel prick test. It is a heel prick test to measure immunoreactive trypsinogen in the blood. This immunoreactive trypsinogen, it is a pancreatic enzyme which is elevated in cystic fibrosis, and this newborn screening test detect that enzyme. So if increase in immunoreactive trypsinogen, next step is to do DNA analysis to detect the cystic fibrosis gene mutation to confirm cystic fibrosis. So these are the tests to detect the cystic fibrosis. Next question. Management of acute myocarditis. The first step in any disease management is initial evaluation and stabilization. Start oxygen therapy to maintain SpO2 more than 94%. In myocarditis, avoid fluid overload. Restrict fluid and sodium. Monitor for arrhythmia. Continuous ECG monitoring. After the initial evaluation and stabilization, the second step is medical management. If the signs of heart failure, or shock, start the inotropic support. The milrinone is preferred inotrope. The other choices are dobutamine or epinephrine. Start diuretics. If there is pulmonary edema, for afterload reduction, give captopril, enalapril. If arrhythmia, give amiodarone. After the stabilization and basic medical treatment, identify and treat the underlying cause. Treat that underlying cause behind the myocarditis. If there is infective cause, most commonly myocarditis is caused by the virus load. In case of viral myocarditis, the treatment is supportive. Antibiotics if suspicion of bacterial infection. Autoimmune, of the inflammatory cause. Corticosteroid. And plus minus immunosuppressive therapy. If no cause identified, we can give trial of immunomodulator therapy. That is IVIG. Dose of IVIG is 2 gram per kg. Single dose over 24 hours. If refractory heart failure, start ECMO, extracorporeal membrane oxygenation, or left ventricular assist device. Along with this, activity should be restricted. Activity restriction to reduce the load on the heart. No strenuous activity. for 6 months. Regular echo and ECG. This is the management of acute myocarditis. Next question. Treatment of organophosphorus poisoning. First of all, what are the organophosphorus compounds? Organophosphorus compounds are cholinesterase inhibitors. That means they inhibit the enzyme which destroy the acetylcholine. So as a result of organophosphorus poisoning, the concentration of acetylcholine is increased. That causes accumulation of acetylcholine at synapse and neuromuscular junctions. And this leads to overstimulation of the following receptors. So the receptors which are stimulated by acetylcholine, they start acting more. The muscarinic receptor, nicotinic, and some CNS receptors. They get overstimulated. Acetylcholine is increased in OP poisoning. So what is the treatment? Initial stabilization, to secure airway. Airway should be patent. Do suction regularly because acetylcholine increases the salivation and the secretions. Early intubation if required. Then focus on breathing. Give 100% oxygen. Circulation. Maintain BP. Start inotrope if required. The most important thing in poisoning is decontamination. Remove the contaminated clothes. Wash skin thoroughly. With soap and water. We can give activated charcoal. If ingestion is in 1 hour. The next definitive therapy is antidote therapy. So the antidote for OP poisoning is atropine. Atropine is an anticholinergic agent. And the mechanism of action of atropine is it blocks muscarinic effects of excess acetylcholine like salivation, bronchoria, and bradycardia. It blocks these effects. The dose of atropine 0.02 to 0.05 mg per kg IV and repeat every 5 to 10 minutes and repeat until the signs of adequate atropinization achieved. What are the signs of adequate atropinization? So there is drying of bronchial secretion, and decreased salivation. Heart rate started increasing more than 80 to 100 per minute. Pupil mid dilated. Skin become warm and dry. Just continue atropine until these signs achieved. Second antidote is enzymes. Example is pralidoxime and opidoxime. These are the cholinesterase reactivator. This increase the activity of cholinesterase enzyme which destroy the acetylcholine. Other thing is benzodiazepines. For seizures. So this is the antidote therapy, give atropine and Alzheimer's. And at the end, do continuous monitoring. Continuous cardiac. Respiratory monitoring. Serial. Cholinesterase levels monitoring. This is the treatment of organophosphorus poisoning. Next question. Snake bite and venomation. Clinical features. So there are 4 types of snakes commonly seen in India. Cobra and crate. This is neurotoxic. Russell's viper and saw-scaled viper. They are vasculotoxic or hematotoxic. The clinical feature starts with general features. We can see the fang marks. Pain and swelling at the bite side. Bleeding or oozing. Discoloration. Regional lymphadenopathy. Necrosis. The systemic features. Features are divided into 3 categories. Neurotoxic, Neurotoxic envenomation. Early features. Ptosis, which is drooping of eyelid, and it is the first sign. Diplopia. Dysarthria. Dysphagia. Drooling of saliva. Weakness of neck muscles. And blurring of vision. And progressive features. Respiratory paralysis, which leads to respiratory failure. Diminished or absent DTRs. But consciousness remains preserved in snake bite till the hypoxia occurred. The next is hematotoxic or the vasculotoxic. The local signs. The pain and the swelling at the site of bite. The chymosis. Blistering and necrosis. And the systemic features. Bleeding from gums. Nose. Hematomasis. Hematuria. Melanoma. Subconjunctival hemorrhage. Hypotension. Oliguria or anuria. And ultimately DIC. Lab, there is a bedside test. This is the 20-minute whole blood clotting test. In snake bite, especially viper snake bite, there is a failure of clot formation. It suggests viper envenomation. Other test, there is prolonged PT avidity, clotting time, and decrease in platelet count. This is the features of hematotoxic snake. The third variety, myotoxic. This involves muscles. Muscle pain, tenderness, stiffness, and that leads to dark colored urine. That is cola colored. And this due to myoglobinuria. And this myoglobinuria, it also leads to renal failure. There is elevated CPK levels in the blood. So this is the clinical features of snake bite and venomation. Depending upon the type of the snake bite, the features can be neurotoxic, vascular or hemotoxic, and the myotoxic. The next question. Clinical features. Of tyrosinemia type 1. There is defective pathway of conversion of fumarate acetoacetate, that is fumarate acetoacetate. It converts into fumarate plus acetoacetate with the help of fumarate acetoacetate hydrolase. Type 1 tyrosinemia. It is caused by deficiency of that fumarate acetoacetate hydrolase enzyme. This leads to accumulation of toxic metabolites. like fumarate, acetoacetate, and succinyl acetone. And this accumulation affects liver, kidney, and CNS. It is also called as hepatorenal tyrosinemia. The tyrosinemia type 1 is also called as hepatorenal tyrosinemia. And it is the autosomal recessive disorder. First clinical, there is hepatic manifestations. Hepatomegaly, jaundice, vomiting, hypoglycemia, the child will be failure to thrive, because of liver involvement. There is bleeding diathesis, and it can progress to acute liver failure, can be chronic liver failure, or hepatocellular carcinoma. The renal manifestations. There is proximal renal tubular dysfunction, and it is also called as Fanconi-like syndrome. And the features are phosphaturia, amino acid union, glucoseuria, polyuria, and this phosphaturia leads to hypophosphatemic rickets. The renal manifestations, neurological manifestation, there is episodic painful neuropathy. So there is severe abdominal pain, Peripheral neuropathy. Hypotension. Autonomic instability. And ultimately leads to respiratory paralysis. This resembles acute porphyria. So this is the feature of tyrosinemia type 1. So important is there is deficiency of fumarate acetoacetate hydrolase. That leads to accumulation of toxic metabolites like fumarate acetoacetate. And this affects liver, kidney and CNS. And it is also called as hepatorenal tyrosinemia. So this completes the December 2018 paper 3. 2-3 questions are remaining. I will provide the PDF for that questions. And we'll end the class here.